ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. This is Dr. Manjunath Awadkhan. Welcome to my YouTube channel again. Let's learn medicine together and in a very simplest possible way. Today I will be discussing about erythrocyte sedimentation rate, which we are learning since our second year MBBS. It's important to know in and out about ESR. It is a non-specific blood test used to support diagnosis along with other tests. ESR alone has no meaning until and unless it is supported by other lab tests and clinical features. It's a rate at which erythrocyte settles down. Erythrocyte sedimentation rate used to monitor disease and response to treatment in conditions such as septic arthritis, rheumatic heart disease, and other inflammatory conditions. Here is a question. ESR was first described by, and options are pathologist, pediatrician, microbiologist, surgeon, and orthopedician. And answer for this question is surgeon. ESR was first described by a British surgeon named John Hunter in a war-wounded patients. He is also considered as father of scientific surgery. Bernanke reaction. ESR is also called as Bernanke reaction, as Bernanke refined ESR after John Hunter. Later, Western standardized it. At the end of this lecture, you will be able to answer why ESR is high in anemia, female, old age, what happens to ESR value in pregnancy, what is ESR value in dehydrated patients, methods of ESR, which method you would prefer in an inflammatory condition, what is micro ESR, how it is done, where it is used. If you know answer to all these questions, then your concepts are very clear. If you don't know, then also it's okay. It is never late to clear our concepts. Physiology of ESR. Specific gravity of RBC is more than plasma, so RBC slowly settles down at the bottom of the tube. Here we have mounted blood with anticoagulant added in a test tube. After 1 hour, we noticed RBCs have settled down, and above there is a plasma. In between the both there is a buffy coat containing WBC and platelet. Composition of blood. Blood mainly composed of plasma and blood cells. Plasma contributes 55% containing water and protein, and RBC contributes about 45%, which is hematocrit. And in between the both there is a buffy coat containing WBC and platelet, which contributes less than 1%. Stages of erythrocyte sedimentation. Erythrocyte sedimentation occurs in 3 stages over 1 hour. First being Rolex formation, then settling, then packing. Rolex formation in 10 minutes, then 40, then last stage being 10 minutes. Rate limiting step here is Rolex formation. What is Rolex formation? It is a sticking up RBCs and arranging in a pattern of stacking up coins. Why RBCs repel each other? They are negatively charged, so same charge repel each other. Whenever we have a very high RBCs, very high, that means we have very high negative charges, that means less Rolex formation and less ESR. Role of acute phase reactants and immunoglobulins in ESR. Acute phase reactants like fibrinogen and immunoglobulin, when they are present in the plasma, they neutralize negative charge on the RBC, so Rolex formation will increase, so ESR will increase. There are pro-sedimentary factors and anti-sedimentary factors. Pro-sedimentary factors will increase the Rolex formation, and anti-sedimentary formation will decrease the Rolex formation. Pro-sedimentary factors are like acute phase reactant, fibrinogen, immunoglobulins. Then anti-sedimentary factors like albumin will decrease the Rolex formation. What happens to ESR in sepsis? Sepsis, there is positive acute phase reactant, there are negative acute phase reactant. So fibrinogen will increase, albumin will decrease, and both will help in increasing the Rolex formation, and both will increase the ESR. So sepsis has high ESR. What happens to ESR in polycythemia and anemia? In polycythemia there are a lot of RBCs, so more negative charge, more repelling, and less Rolex formation and less ESR in polycythemia. In anemia there are less RBCs, less negative charge, less repelling, and available plasma protein are able to neutralize RBC, so more Rolex formation and more ESR will get in anemia. Female Pregnancy, old age, comparatively RBCs are less, so comparatively ESR will be high. In children, comparatively RBCs are high, so ESR will be low compared to adults. What happens to ESR in microcytosis, spherocytosis, sickle cell disease? To Rolex to form normally, normal shape of RBC is necessary. In all these conditions, normal discoid shape of RBC is lost, so less Rolex formation and they will have less ESR. Very high ESR, that is in 3 digits, will get in aplastic anemia, malignancy, collagen vascular disease and other conditions like TB, HIV and sepsis. Methods of ESR can be done by Westergreen's method, Wintrup's method, micro ESR and automated analyzer. What is the main difference between the Westergreen's method and the Wintrup's method? In Westergreen's we use pipette and Wintrup's we use tube. Length of Westergreen is 300 mm, wherein Wintrup's is 110 mm. Internal bore diameter is 2.5 in Westergreen's and 2 mm in Wintrup's. Known as pipette because it is open at both ends and it is tube. Westergreen's is calibrated from 0 to 200 mm in centimeter also, from top to bottom. It is used for only ESR, wherein Wintrup's used for ESR as well as hematocrit, as it is marked on both sides from 0 to 100 top to bottom as well as 0 to 100 bottom to top. Wintrup's measures ESR only up to 100 mm. Above 100, if you are suspecting above 100 mm ESR like inflammatory conditions or RHD, Kawasaki disease, septic arthritis, we should go ahead with Westergreen's pipette. Here we have mounted blood in a Wintrup's tube. After 1 hour there is a settling down of the RBCs, so length we measured, which is 20 mm at the end of 1 hour. Gold standard method for ESR options are Hunter method, Wintrup's method, Westergreen's method and Bernanke's method. The answer is Westergreen's method. Till now Westergreen's method is considered as gold standard method among all these. If you have a automated analyzer, then go for automated analyzer because it tackles technical factors also. Here is a message of senior doctor to junior doctor: send ESR of suspected RHD kid. What is wrong in this text? And the answer for this is always mention method of ESR. Wintrup's only up to 100 mm. So request for Westergreen's method, which is gold standard. In reading ESR also you need to check whether the ESR is done by Westergreen's method or Wintrup's method. Technical factors altering ESR value. Technical factors increasing ESR value are increase in temperature and direct exposure to sunlight will decrease viscosity, so it will increase erythrocyte sedimentation rate. Tilted tube and vibration will also increase ESR. Every 3-degree tilt will increase 30% of ESR. And bubble formation in the tube will increase ESR. Technical factors decreasing ESRs are delay in processing more than 2 hours, which will lead to spherical shape of the RBCs, which will lead to decreased Rolex formation, which will lead to decreased ESR. Clotted blood will lead to decreased Rolex formation and decreased ESR. Micro ESR, it's used in neonate for sepsis screening. Amount of blood needed is only 4 drops. Bedside test by heel prick method. More than 50 mm at the end of 1 hour is positive. Tube needed is heparinized microcapillary tube of 7.5 cm. In micro ESR we need not to prick vein. Venipuncture is not required. Only heel prick is enough to get the blood, and blood is sucked in capillary tube and clamped it and mounted over a wall with a micropore and read after 1 hour. Normal value can be given by day applied plus 3 up to 15 mm is considered as normal. Above 15 mm it is considered as positive screening test. Automated ESR analyzer. Automated ESR analyzer are considered as gold standard as they tackle technical factors also. The principle is they calculate ESR mathematically from early stages of Rolex formation, that is before 10 minutes of the 10 minutes. The advantage is very rapid, not affected by environmental factors. They have a inbuilt printing and barcode. Here is a question. 7-year-old male child came with complaints of multiple joint swelling with pain and morning stiffness since 4 months. CRP was 180 and ESR was 130. Diagnosis of JIA was made and started on immunosuppressive therapy. Gradually symptoms improved. CRP decreased to 20 and ESR to 15. After few days of initial improvement, child came to emergency with history of high-grade fever, poor oral intake and decreased urine output. At that time, sepsis was suspected, septic screen was sent and antibiotics started. CRP rose to 200 and ESR dropped to 8. So what is your diagnosis? So this is a typical case of macrophage activation syndrome. So why ESR is low in HLH and macrophage activation syndrome? There is low fibrinogen in both condition, and so fibrinogen is pro-sedimentary, so less Rolex formation, low ESR. The fall in ESR occurs secondary to fibrinogen. The major driver of ESR degradation as a part of consumptive coagulopathy and decreased synthesis that due to liver dysfunction that occurs in HLH or macrophage activation syndrome. So how to calculate corrected ESR in anemia? Anemia will have generally low ESR because very high ESR because more Rolex formation. So we use Fabry's formula for that. So corrected ESR, measured ESR into 15 divided by 55 minus hematocrit. Thank you.